Thank you for a great uh, introduction. So, hi again, I'm Mariam. I know it's very late, but I'm going to be quick. And good news that I'm the last person, so we're good. So, today I'm going to present my PhD topic, but here I want to mention that originally my PhD topic was not an implementation research. So, I'm going to present whatever we did within the PhD. And then I'm going to present the idea which could serve as a potential grant for R21. And of course, it is a pleasure for me to listen to your ideas, thoughts, some questions to me. But yeah, thank you. It will be very nice. So, in a whole, I had three objectives within my PhD topic. First one was scoping review. So this was quite a headache. We've developed, yeah, everybody knows that. We've developed a big search term, and we searched for alcohol use disorder, substance use disorder, mental health, anxiety, depression among PLHIV and key populations. And we used the tool Covidence. So we gathered all this information there. We screened the titles, then the text. So we've got some results finally. And as we saw from the scoping review, there is high prevalence of mental health disorders among PLHIV and key populations. Of course, there is high prevalence among AUD and of AUD and SUD among PLHIV and key populations. So what was the the hardest was that there is a diverse array of instruments which were used to measure either depression or anxiety or AUD and SUD. And also there was a broad array of outcomes ranging from general symptoms to major depressive disorder diagnosis and so on. So this was quite a big challenge associated to somehow synthesize the findings across the study. So we struggled a lot, to be honest, but we have developed a draft manuscript. So yeah, this is like one study, which this was my first objective of my PhD. The second one was the original study, which was conducted among Georgian harm reduction centers. So the name is that substance and alcohol use disorders and HIV testing uptake among people who inject drugs in Georgia. So we had the convenience sampling. In the whole, we had 300 people who inject drugs within the harm reduction centers. So the results were quite interesting, at least to me. So 100% of PWIDs who had, it was 100% who had some kind of SUD ranging from low to severe. As you see, 55, almost 55 had low alcohol use disorder, while 46% had increased to severe alcohol use disorder. More than 60% had mild to extreme depression and anxiety. And what was quite typical to Georgia and also interesting that having moderate to severe SUD or mild to extreme depression was significantly associated with ever being tested for HIV, and the odds ratio is 4.7 and 1.0 respectively. So whoever had more severe condition, they were more tend to test. And this is quite typical because whenever you're not feeling very bad in Georgia, you're not going to doctor or test or do anything else. Another also within that study, we have identified some gaps between perceived needed utilization of services. So out of 300 individuals assessed, 48 perceived the need for services, but only 24% used the services. Also, this was regarding the substance use disorder. Among 137 individuals, only 2.2 utilized the alcohol services, and from a group of individuals of 183, for depression, 26% perceived the need for services, but only 9% utilized them. So there is big gap between perceived need and utilization, and the same is for anxiety. So only 24% perceived the need, and then only 8% utilized the services itself. And the third and the last objective of my PhD is mapping of mental health services study. So this is a study where we ask service providers what kind of services do they have. We contacted all of the mental health facilities and narcology facilities which exists in Georgia. And this study is ongoing. It's almost finished. So these are like preliminary results which were highlighted from the study. So there is a huge system challenge, treatment, and there is geographic disparities because like significant issues are regarding mental health and narcology field because those two are divided and they hinder person-centered care. We have treatment gaps because like we lack the guidelines, protocols, and screening tools for PLHIV in the facilities itself. And also there are many nice services which are located only in TPDC and not in the regions. But of course we have regional access as well. So from now on, everything is beyond my PhD. So we've thought of like two evidence-based intervention. One is SBIRT and one is ASSIST. So SBIRT stands for screening, brief intervention, and referral to treatment, and ASSIST is alcohol, smoking, and substance involvement screening tests. So the goal of SBIRT is to prevent or reduce substance use to prevent health consequences, disease, accidents, injuries, while ASSIST goal is to identify and manage substance use issues to reduce health risks. So both are validated. SBIRT is applicable by various staff in multiple settings, while ASSIST is suitable for use by health professionals in various settings as well. It's successful in low resource settings, and ASSIST is broadly supported by WHO, and both tools are translated and validated by Dr. Irma's and Tato's organization. ASSIST, it's on the CPR, yeah? It's translated, yeah. So, and before we plan any kind of intervention or implementation research, we should ask several questions, yeah, during pre-implementation, implementation, and post-implementation. So what are the contextual barriers and facilitators to implement this evidence-based intervention among PWID in Georgia? What strategies should we have that can address those barriers? During the implementation, where are the SBIRT and ASSIST components and strategies implemented with fidelity? Are there strategy components that need to be refined? Is the strategy to increase the uptake of this evidence-based interventions? And in the post-implementation, what are the costs, for example, of those strategies? And like what are the barriers and facilitators to sustain the effectiveness itself? So for this to have like good implementation research, you should come up with a good framework as well, which we talked like for 2 days. And we decided that we could have the consolidated framework, the CFAR, which will be used during the pre-implementation assessment, and we will do the pilot testing to assess the implementation and intervention outcomes as well. And also, maybe in bright future somewhere else, we could do the RCT, where we could use, for example, mixed methods, hybrid type 3 cluster RCT design. And due to the fact that now we all know very nicely the differences between types, we can use like different type as well. And here we could have like intervention group 1 and group 2, and of course the control group. So in intervention group 1, we will use ASSIST tool to identify the substance use and deliver the brief intervention. In the second one, we'll use the tool, deliver the intervention, and guide participants through the self-help strategies. And in the third one, we will use we will just use standard care without ASSIST intervention. And we will have some primary and secondary outcomes as well, and implementation outcomes. So in primary, we will have like reduction in substance use measured by follow-up and follow-up asset scores. We will have referral to and uptake of further treatment services. And in secondary outcomes, we will have engagement in harm reduction services, improvement in overall health well-being. And of course, like in implementation outcomes, we will have fidelity, acceptability, feasibility, sustainability to assess adherence to the intervention protocol, measure participant and staff satisfaction, itself to implement the assessed intervention in the setting, and assess the potential for long-term integration within the services, like into. So here we were thinking to have the harm reduction network itself to, because all my studies, which I'm conducting within my PhD, it's in harm reduction center, that objective. Yeah. Good. Yeah. So thank you so much.